Hi everyone, welcome to Women Empowerment Shadowing Session. Today we have Dr. Sukaina with us who will be talking about head and neck surgery. Thank you, Dr. Sukaina, for joining us today. Whenever you're ready, please begin your presentation.
Hey everyone. So I'm Sukaina Hasni. I'm a third year ENT resident at the University of Oklahoma right now. So I'm just kind of going on and letting you guys know about myself. So I actually was doing speech therapy in undergrad. So my undergrad degree is in communication sciences and disorders. And I also did another degree in psychology. Come, it was like I think it was senior year during finals where I decided that I don't want to do speech therapy. They put us in this clinical course and where we were in the clinics and actually, you know, uh, seeing patients. And I didn't find it to be something that I was fully interested in, I guess. So I decided to switch over at that point, and I had two options. I could have either gone to an American medical school, but I would have had to study and take my MCAT, or I could have gone to the Caribbean. And I chose to go with the Caribbean just because I didn't want to take any time off. Um, and going into the Caribbean, I didn't anticipate the barriers that kind of come with being an IMG. I went in wanting to do ENT from the get go. My whole thing has been to kind of revolve my career around my baby brother, who's got bilateral cochlear implants, which is why I was thinking speech therapy initially. And then when I decided to switch into medicine, why I wanted to do ENT. But yeah, so I went to the Caribbean. I went to St. James, which is on Anguilla. It's like kind of right by St. Martin in Puerto Rico, if you guys are kind of familiar with that area. You do 16 months over there um, on the island. So that's your basic core. And afterwards, you come back and you do rotations in the States. So most of my rotations were done in Chicago and Michigan. Um, and then at the same time, while I was in medical school, I also was doing online masters. So I got a master's in healthcare education and promotion and a master's in healthcare administration. I definitely think that that was a big point when it came to my interviews. Definitely was a talking factor with almost everyone that I interviewed with. And I didn't just do it on the side just to kind of have it. I'm actually very interested in the way that healthcare works, in the way that we utilize our resources. And eventually, I would do want to go into more of an administrative position when I'm kind of going towards finishing operating permanently. But yes, so that's kind of what motivated me to get those master's degrees. And then obviously now I'm doing my ENT residency, which is a 5-year residency program. I'm finishing up my third year at this point, so I'll have 2 more years to go. I'm debating on what to kind of do next afterwards. So just kind of going back a little bit and talking about medical school. Um, sorry, one second. Medical school. It's not letting me go back. There we go. And the different pathways that you can kind of take. I don't know if a lot of you guys are pre-med at this point or already in medical school, but there's a couple different things that you guys can do. Um, So you can go to an American medical school, in which case, you do your, in undergrad, you do your biology, your chemistry, and like all of those prerequisite classes. You take your MCAT, and then you go to an American medical school. Even within that, there are differentiations between an MD and DO program. However, now the match process clumps them all together. So DO schools now have to take both their complex, I believe, as well as step one and step two and step three, like MD programs. I don't think that educationally there's much of a difference that should sway you to avoid DO schools. Although I think DO schools actually kind of teach you a little bit more in terms of holistic medication medicine, which uh, MD schools don't teach you. So it's kind of nice if you do decide to go the DO route, and your opportunities are the same now because the ACGME is now the same, and your residency opportunities are the same. So you're not really competing. Well, you're competing with MDs, but you're not being looked down upon, or you won't get denied because you're a DO. You can also go to the Caribbean, which would be like a next level. So in the Caribbean, there's so many schools to kind of choose from. I would say do your research in terms of which school you're applying to and what accreditations they have. Each one is different. There's different tiers. So you can always Google to see what accreditations they have and what accreditations they'll need. You can reach out to students from their school, from that school. I would say find your own students instead of going with the students that they're going to recommend to you, mainly because I feel like they're going to recommend students that are going to just talk good about them, which obviously, it's that's expected. But I would really say do your research, because there are some schools out there that don't really give you much guidance in terms of even the basic cores. There's classes aren't as well developed, I guess you could say. They don't give you much guidance once you come back in terms of rotations. Their rotations are very sketchy, and they give you zero guidance in terms of steps and applications themselves. So I would look into that. I would ask them for their step one pass rate, although I will say that I think going to any medical school pathway that you decide to do, I think that your studying techniques are going to be your own, and it's not going to relay over to what you're really learning in school, because step is very different than the curriculum that you're going to be taught. The other option that you would have is to be a total IMG, so international medical grad. So you can go to places like Pakistan, India, Europe, and they all have programs where you would do a certain number of years over there and then transition back over to the US for residency. So that's always a possibility to look at. I know even Dubai has something like that. So there's tons of different ways to get to becoming a doctor if that's something that you guys are interested in. Sorry. So a little bit about ENT. It's also called otorhinolaryngology or otolaryngology. Um, I put the pronunciation on there because people don't usually know how to pronounce it, which is why we just kind of refer to ourselves as ENT. The other thing is if we try to call ourselves ORL, it ends up getting confused with OMFS, um, which is oral maxillofacial surgery. And that's the MD DDS program for the dentist can go through. It's actually kind of funny. My first day in residency, I was on a peds surgery rotation because we had to do 6 months of general surgery when we first start. And it was my first day. It was a Sunday, so I was taking a 24-hour call by myself. I didn't know how to work the EMR system or anything, and there was no other resident, attending, fellow, anyone available to me to kind of help me out. And it turns out that they put it that way because they assumed that I was actually a second year OMFS resident rather than a first year ENT resident. So the confusion happens very frequently. So we just like to keep it simple and call ourselves ENT. So our scope of practice kind of involves everything within the head and neck. And I think that's one of the reasons that I've continued to grow in terms of my passion for ENT. So within this area, whether it be a fracture, whether it be something vascular, whether it be a cancer, whether it be medical, such as sinusitis, we don't need any other specialty to help us. We can take care of anything within this anatomical area, which I think is very different than other subspecialties. You can go into, you know, breast oncology. So that's just one area and you're doing just oncology. You can go into GI and that's one area, but they usually will refer to the surgical oncologist in terms of their cancer, and they'll refer to, you know, medicine in terms of treating like GERD. They're not going to treat that for you. But for us, within this area, we'll treat anything. If there's a fracture, we don't need ortho. If there's vascular issues, we don't need vascular surgery. We'll do things in the skull base. So we don't, I mean, technically we can take out certain tumors from the skull base without the help of neurosurgery. So depending on where you're at, I mean, if you have a good relationship and that's the way you guys work, you'll work alongside neurosurgery. But otherwise, you have the capability and the skills to go ahead and do those things by yourself. So I just feel like it makes ENT really kind of stand out, and I know that that's why it continues to stand out to me today. The other thing I kind of like is that you're treating the face. The face is how you communicate with the world, it's your identity, and we have the potential to help someone out with whatever issues they may be having with their face. So, in terms of fellowship potentials, so ENT is already subspecialized, as you guys know. So, you do 5 years, you get trained in all of these things, and you come out and you can work as a general ENT. And in the scope of practice for general ENT, you can technically do anything that you're comfortable with. So, you don't need to be fellowship trained to do anything that's listed on this slide over here. But if you do want to specifically do those things and not have a general scope of practice, you can do fellowships in head and neck. So there's ablative, which means removing cancers, or microvascular. You can do both. And microvascular would be recon. So, we do flaps all the time, or we'll take a fibula and recreate it, recreate someone's mandible with the fibula. We'll do, an anterior lateral thigh graft, and we'll recreate the tongue with it. So there's a great potential in that category. You can definitely do ablative things without a fellowship. You can even do microvascular recon if you want to. It's just something that comes with a lot of responsibility. So most general ENTs won't do it. Rhinology, so that's sinus surgery, you know, and sinus surgery comes with more than just treating sinusitis. There's a whole bunch of different disorders. There's different procedures. In rhinology, you do a lot of skull base. You can do things in combination with neurosurgery. You can do things in combination with ophthalmology. So that's definitely a fellowship potential. The other one is skull base. Skull base can be one of two routes. You can do it through rhinology, or you can do it through otology. Otology is another fellowship as well. So that's ears, cochlear implants, middle ear disease. Any of that stuff kind of falls within the otology spectrum. And also, so again, skull base, so they'll do acoustic neuromas and things of that nature. Pediatrics is a fellowship that you can do. So within the scope of pediatrics, obviously you have your tonsils, tubes, adenoids, the basics, but pediatrics, ENTs do airways, they do exit procedures, which means, if the OB-GYNs have recognized that the mom has polyhydramnios and there's something obstructing the baby's either swallowing or their airway. So we'll be present for at the time of C-section to see, once the baby comes out, can the baby breathe? If not, we can do emergent intubation or tracheostomy right on site. Facial plastics is another fellowship potential. So that's all of your blepharoplasties, facelifts, nose jobs, and that also entails recon. So facial plastic surgeons do a lot of reconstructive surgeries as well. Laryngology, so treating the voice box. So that can be anything from voice cancer to voice abuse and vocal cord nodules to respiratory papillomatosis. And laryngology is actually one of the coolest things that we have. There's lots of use of lasers and microscopes and telescopes. And it's honestly, all of ENT has very cool gadgets, but laryngology it's a very microsurgery based. So it's very cool. And then craniofacial is a fellowship that can kind of go along with peds, and that has a lot of recon to it. So you can do, in terms of pediatrics, like cleft palates and things of that nature. So I did kind of want to touch base in women in otolaryngology. I do think that being a surgical subspecialty, we've been really working towards, you know, um, focusing on developing a more comprehensive group of residents. I think every program is very focused on that. So obviously, overall, there's still a lapse, but we're working towards it. So as you can kind of see over here, um, in department leaders, this is in terms of percentage. Obviously, it's a low percentage of department leaders that are female base, but I don't know if you guys can see my cursor or not, but Dr. Cannon, she was one of our head and neck attendings who is now over at Duke in Raleigh. And, she is in a leadership position. She's always been in leadership positions. And, it's definitely one of my role models. So it's not that it's not doable. It's just right now, since it's such a subspecialized field, it's something that we are working on. And faculty members, obviously, still a low percentage, just because overall, in the past there had been lower numbers of females wanting to go into ENT. Again, it comes with that whole stereotype of a surgical specialty, especially subspecialty, and a 5-year residency program, and all of those things. But if you kind of take a look, overall, in terms of residents, we are reaching up to that 50% mark. As you can see, like, this is my residency program, and there's a whole bunch of us females. In my class, there was only 2 of us, and both of us are females, myself, and then Erica, my co-resident. Um, Currently, we have a 50-50 ratio in my program of males and females in our resident cohort. And, our attendings are very, very proud. This is Dr. Crumple over here on the right-hand side. He's the one that requested that picture because that was actually his first time having an all-girl rounding team for a weekend. So it's definitely something that we're working on. Even within our national organization, the Academy, we have a sub organization now called Women in Otolaryngology, and then there's divisions in that. So there's Women in Rhinology, Women in Laryngology, and et cetera, et cetera. So definitely something that is being worked on. And I definitely think that in terms of going into ENT as a female, a couple things, I don't think that there's obstacles in terms of how you're treated. I think I have been treated with the utmost respect, and I've never felt inferior to my male counterparts. Um, I don't think that I'm, also part of a couple positions within the residency groups and things of that nature, and I've never felt a barrier to obtaining those positions. And I think, I've discussed it with Dr. Cannon numerous times, and there's not really barriers as long as you're motivated to be in a leadership position. I don't think that this career will hold you back from that. Now, with that being said, the stereotype that comes with a surgical subspecialty, I don't think that fits ENT very well. I think that as any residency program, doing ENT is going to be difficult. Residency is going to be some of the most testing times of your life, and that's okay. That's what you should go in with. That's the mindset, and you'll make it past. And then once you're done, ENT surgeons actually have a very good lifestyle. I mean, if you can decide your schedule, most people that I know work 4 days a week, and they if you're in private practice and working out of a surgery center, you're not really ever taking call. So it's actually pretty good. And if you go into head and neck and you're doing microvascular surgery, then yes, you might have like a 12-hour case. Otherwise, most people's schedules are, like 8 to 5, 8 to 4. So it's a really good lifestyle to have as a surgeon. And I don't think it withholds you from living your life in any way that you may feel fit, whether that be having a family, being single, traveling, whatever you want to do. So a day in the life of an ENT resident, I kind of wanted to give you guys my current my current routine. It really just depends on the rotation that you're on and whether you're in clinic or the OR, and that kind of changes on a day-to-day basis. Rotations change almost on a every 2-month basis. So if I'm in clinic, I have my morning routine. If I wake up early enough, I'll work out if possible. Then I come to the hospital. I prepare the list. I am a junior resident right now. So junior residents are responsible for the list. You're responsible for holding the pager. And so, you're learning. So there's a hierarchy system, and you're at the end of it at the moment. So you prepare the list, and then you wait for your chief to come. Then you round on your patients, and then you guys will go to clinic. And in clinic, we see our own patients in our Wednesday resident clinic. But if you're in clinic with an attending, you still go see the patient first. You work up the patient, you examine the patient. If the patient's there after sinus surgery, you debride their nose. You have not really any restrictions. You are a self-functioning physician. But then you'll go back out, you'll run the patient by the attending that you're working with that day. and then you will go back into the room with that attending and see the patient with them. Um, in between patients and sometimes at lunch, we will run around, especially as a junior, if you have any consults throughout the day because you are carrying the pager, you'll go and run and see those consults, grab some food, come back. And then you do clinic for the remainder of the afternoon, and then you'll round and or see consults before you finish off your day, and then you'll check out. So our checkouts aren't as formal, I think, as internal medicine programs or anything of that sort. We all kind of just call each other, call the person on call, and just let them know that, hey, this is who's on the list, this is what you need to be worried about, and this is what you need to follow up on. And then the same thing in the morning. If I'm in the OR, then that gets a little taxing, but OR days are the best days. You have your morning routine, you do what you got to do, get to the hospital, prepare the list, and then you'll wait for your chief, and then you'll round. Then after rounding, you go to pre-op, try to pre-op the patients for the OR that are already there that day, try to finish up as many notes before they roll back. You'll operate, and when I say you'll operate, I've been operating since first year. It's one of the best things about ENT is all of our attendings are very trusting, and they're wanting to teach. So if you, I mean, it's not just if you ask, I mean, you are expected to operate. Your attending's there, they're walking you through the case. If there's any part that you feel like you don't feel comfortable doing, they take over, they'll do it. But I do think that, like, we get operating experience from day one, and it's great. And it really builds up your confidence that by the time you're even a third year, there's the majority of things that you probably will be doing out in private practice, you're comfortable doing already. In between cases, you'll run and go see your consults because you're carrying the pager, and then you'll go pre-op the next patient for your room. After you're done with the OR, then you do post-op rounds, finish up any consults that you didn't get a chance to see, and write your notes, and then go home, and then obviously check out on the phone. Just a little bit about kind of holding the pager. So for us, we hold the pager throughout the day. You are the on-call person for the day, regardless of whether you're in the clinic or the OR. And then if you're on call at night, so we do home call. So what that means is all of the teams check out to you if you are the junior on call. You get to go home too after you're done with your work day, and you chill at home, do whatever you need to do, like in terms of regular life. And then if you get a consult, if you get a nursing page, if you get anything like that, then you can answer that from home. If you have a consult, you'll go see it, but then you come back, you can write your note at home. There's no real restrictions. You have a hierarchy system. Even at night, there's a chief on call with you. The chief does not come see the consults. You will work up the patient, call them afterwards, let them know your plan. If they agree, that's fine. You'll go ahead and go with it. If they feel like the patient needs to be admitted or anything of that sort, or if the patient needs to go to the OR, then they'll call the attending on call, and they make that call from there. You do work the next day since you are home call, so it's expected that you're hopefully getting enough sleep. But if you do have a crazy busy night, our chiefs are really good about being like, no, just go home, go and sleep it off, get refreshed, and then if you want to come back, you can. If not, we'll see you tomorrow. So I do think that I personally like doing home call better, because you will have some days which are no hitters, and you basically worked a call night and didn't have to go in at all. So it's kind of nice, rather than being in the hospital and kind of messing up your sleep cycle. So you guys, is there any way to kind of make the cases interactive, or is that not possible?
I believe there's a delay between YouTube and Zoom, so I'm not sure whether we're going to be able to make it interactive.
Okay, no worries. So just kind of quick cases that I wanted to run with you guys, just so you guys can kind of see the type of things that we kind of see in clinic, and things that we might operate on. So this first case is an otology case. It's a 30-year-old female who complained of bilateral hearing loss, more on the right side. She came into our clinic after delivering her first child. The hearing loss was more significant in quieter environments and improved in noisy environments. So her audiogram showed this, and you kind of see that right here in the 2000s, you lose the air bone gap, and there's a little bit of a notch, and then it goes back. So when you looked at her ears, you saw that both of the tympanic membranes appeared normal, but you saw this reddish hue. I don't know if you guys can see my cursor or not, but you saw this reddish hue on the middle ear. Her tuning forks were negative, so that means they were normal. So, sorry, her Rene was negative, so she still had air greater than bone conduction bilaterally. Um, so since I can't, I guess it's not interactive, I'll just kind of walk you guys through this. So there's a disease called otosclerosis, and what that means is that your little ear bones kind of they fuse together and they start getting this bony overgrowth. It's an autosomal dominant disease, but it can also happen in pregnancy. And the characteristic finding on examination is this reddish hue within the middle ear space that you can see through the TM. And on audiogram, it's this little notch in the 2000s. So with this, it depends on the severity of it and the outcome that the patient wants, but there are multiple surgical procedures that you can do. There's tons of prosthesis. So if the otosclerosis has completely eaten through, let's say, the incus, we have incus prosthesis, we have stapes prosthesis, we have an inguinal malleus prosthesis that you can use. And what we would do is it depends on the surgeon and, what type of surgery you want to do. But you can go in, either lift up the eardrum through the ear canal and do this procedure and remove all of that calloused bone, remove those ossicles that have been involved, and then place a prosthesis to restore hearing. Or you can go in from the backside of the ear, drill out the mastoid bone, and all of this is done under a microscope in the operating room. Drill out the mastoid bone and approach it from that aspect. And same thing, remove all of the callous bone, remove the ossicles, and then place your prosthesis, and then just flip the ear back and you suture it, and you can't even see that scar. So just a very interesting thing. I think otology is definitely one of the coolest fields to be in. You use drills, you can do implants. So I don't know if you guys are familiar with what cochlear implants are. So cochlear implants, if someone has severe sensorineural hearing loss and a hearing aid is insufficient for them, you can place an implant. And what you do is you make an incision through behind the ear, you drill out a portion of the mastoid until you can get into the middle ear space. And once you're able to do that, you place an electrode into the cochlea itself, and it helps transmit signal from that external piece that will sit on top of the patient's ear into the cochlea, so it can bypass the defective hair cells that aren't working in sensorineural hearing loss. And it's truly an amazing piece of technology that we have. It is the only sense that we are able to restore. So I do think that, otology is definitely one of the best parts of ENT. Case number 2. So this was, a patient presents to you, a child with their parents, 3 days after getting amoxicillin therapy for acute otitis media. It's a 4-year-old boy, and he continues to have fevers, ear pain, and now he's got this swelling with redness behind his ear. His earlobe is pushed superiorly and laterally, as you can see here. He's otherwise doing well. So the diagnosis and treatment, so this would be acute mastoiditis, and that's when you get spread of a middle ear effusion, an infected middle ear effusion into your mastoid air cells, which are the air cells that sit right behind your ear. And we call them air cells. They're not like, biological cells. They're just septations within the bone. So depending on the severity, the easiest treatment would be to change the antibiotic therapy and place an ear tube. So that's when you go in through the tympanic, in through the ear, place a small little incision into the tympanic membrane, and you place a little tube that allows the middle ear fluid to drain out backwards through this way, rather than going down into the eustachian tube but to the back of the throat. This helps relieve that effusion, and most of the times the mastoiditis will resolve with that. Sometimes it doesn't, and you need to drill out the mastoid. So same thing, you make an incision behind the ear, which is barely noticeable. You flip the ear over and you drill out that bone to release that fluid from that area. And there's actually no hearing. I mean, there's obviously risk associated with the procedure, but overall, there's drilling out your mastoid doesn't cause any sort of hearing loss. So it's just very cool things that you can kind of see. And this would be seen in likely the pediatric clinic or the otology clinic. And it's kind of cool because those things kind of overlap. So the pediatric ENTs are more than capable of drilling out the mastoid if that needs to be done. So they don't need to necessarily send it to the otologist. So I think we can start to take some questions if that's possible from the YouTube chat. And if you guys have any personal questions or any advice that you guys want, you're more than welcome to reach out to me either through Instagram or my email over there.
Thank you so much for your presentation. So we do have some questions on YouTube. The first question is, have you ever witnessed any complexities on the surgery table, and how did you deal with that?
Yes. So the risk that we talk about in terms of surgeries, because you guys have to remember, we do things that are very high risk. We do neck dissections, so your carotids are sitting right there. You can pretty much get in surgery. It's not like Grey's Anatomy. Like knock on wood, I have not seen someone die on the table. So I don't think that like those shows that show you all of those dramatic events. I mean, things like that can happen, but I don't think it's as frequent as those shows may seem. But things that we do definitely have risk factors associated with it. So I can't personally talk about the complications that we've had because that's patient information and HIPAA, but I can give you examples of risk factors. So even with like a simple tonsillectomy, your carotid sits right behind your tonsil. So if you're not careful, one of the complications is going to be bleeding, and the bleeding could technically be from your carotid. And in that case, like there's multitudes of things that you can do. And sometimes you may need to get other teams involved to kind of get control of the bleeding, such as IR to come embolize that area. With neck dissection, same risk factor. Your carotid is right there. When we do thyroids, your recurrent laryngeal nerve is your recurrent laryngeal nerve, which controls your voice box, is within that same area, and you have to dissect it free without nicking it. And if you do nick it, the person's going to have difficulty speaking, possibly breathing, possibly aspiration risk associated. So the best thing that I can say is that when you are consenting a patient in the preoperative area, be honest. Yes, it's scary to list out all of those things that may go wrong prior to taking them back when they're supposed to be trusting you, but it is the most important thing that they understand the risk associated with surgery. When you do come across a risk while you're operating, just be calm. Most of the time, if you're calm, you're going to be able to figure out a solution to a complication. And there are going to be times when there is no solution. And after surgery, be honest. Be honest with your patient that this is what went wrong. This is why it went wrong. We discussed it prior to surgery, and I'm sorry. If you're honest, your patient will understand. If you lie and pretend like it didn't happen until they kind of figure out something's wrong by themselves, that's going to be a problem.
What was the most challenging part of med school? How did you manage your time?
So I think the most challenging part of med school for me personally was trying to figure out my own study technique. So when I came back from the island and then I did my rotations, and when I was studying for step 1 and step 2, I don't think that I don't think any med school honestly teaches you what study technique is going to work for you to pass those boards. And it takes a while for you to kind of play around with different ideas and different ways of studying until you can figure out like your own rhythm. So I think that was the biggest challenge for me. How did I manage my time? I was very strict with myself. I'm not going to lie, but that's just the way I function. If I have an exam or something like that, I can't do anything else. I have to just study. When I was on the island, my roommate and I were both, we both had this deal that like if and I'm not saying that this is going to be the case for everyone else, but we both had this deal that if we had to take a comp exam for any of the classes, we just call it a day and be like, okay, this is not for us, and we're going to leave. Luckily, we never had to do that. We studied pretty much every day. Even though we lived on an island, we gave ourselves weekends and then post exams to be our beach days. It's not like we went every day. We didn't party every day or anything like that. When I came back, it was the same thing. When I studied for step one, the time that I took to study, I didn't talk to any of everyone knew, my friends knew, my parents, everyone, my family members. I didn't really do anything except study. I had my schedule. I, woke up at a certain time, did this many questions. And even then, if I finished ahead of time, I did some more questions. And the thing is, your time will pass and you will, if you're motivated enough, you'll make it through and you'll get that residency position that you want. And then after that, everyone else will still be there. I mean, if they're going to be a part of your life, they'll still be waiting around.
How did you decide that you wanted to be in this field?
So, as I mentioned, my baby brother has bilateral cochlear implants. So, that's something that I kind of grew up seeing. I grew up seeing his potential and what his implants did for him, what his speech therapist did for him, and how it truly impacted his life. It's as if he has no hearing loss at this time. So, I wanted to be able to give back that feeling to somebody else and some other family, and which is why initially I was doing speech therapy, and then when I switched over to medicine, all I wanted to do was ENT.
Have you ever came across a case that had a long-lasting impact on you?
I think all of my cases have long lasting impacts on me. I think that you should walk out of each case. You should walk into each case confident, but also realizing that that's someone's life. And if that's not impacting you, that's a problem. And then you should walk out with having learned something or another and realizing how you actually impacted their life. So in return, that should impact you.
How do you deal with burnout?
So I don't think I'm burned out. I think that there's a difference between burnout and um, uh, mental mental sanity, I guess, or so I focus on myself a lot. I work out every day if I can. Um, I make it a point to be available to my friends and family back home um, whenever they need me. It's not something that I put on hold. And, I travel as much as I can. I think that so when I entered my program, you're in residency, you're allotted a certain number of days off, like vacation days. And typically in a residency program, they are like, oh, you should take 1 week off at a time. And that was a tradition of my program prior to me joining. And then when I joined and I was like, I can't take 1 week off. Like I can't just have three times a year when I'm able to go home and see my family. That I'm way too close with my family. I miss out on so many things. So I asked them if I could just split up my vacation days, and they said, yeah, of course. That's totally not a problem. So now pretty much everyone in my program does. And I do think that, if there's something that you feel like you need for your mental sanity, then you should ask for it. It's not going to, like, what's the worst that you're going to get? Like a no? That's fine. I mean, then you try to figure out another way to get yourself to that mind space.
So, if you're a general ENT, can you see pediatric cases, or are only pediatric ENT allowed to take care of pediatric cases?
No, you can definitely see pediatric patients for sure. You can, as I said, you come out of general ENT trained to do anything. So you can see anything you want to under the sun in terms of ENT if you are comfortable with it. Most of the time, what ends up happening with general ENTs is, for example, they'll see peds, tubes, tonsils, any of that stuff. And they'll do, certain peds airway cases and all of that if they have, obviously admitting credentials at a hospital. But let's say that you get a newborn child who you need to do a laryngotracheal reconstruction on. And you haven't done one of those since residency, and now you're 10 years out of practice. That's when you'd be like, oh, okay, I'm probably going to refer this to the peds ENT guys or the, the laryngology people, like, and let them take care of that, because that's not something that I have done in the past 10 years. So I'm not comfortable with it. It's those rare cases where you're like, okay, I haven't done this since residency. I haven't seen much of it. It's not a common thing. So let me just refer it out.
What's your least favorite thing about your field?
I don't think I have a least favorite thing. I personally am, I think I don't think I have a least favorite thing, to be completely honest. I would say that, flap surgeries can be long, but honestly, flap surgeries are some of the best memories that I have made in ENT. You spending 20 hours in an OR with your attending and your co-residents. I mean, actually ends up becoming a very fun time. Not that surgeries are like, obviously very focused and serious, but at the same time, you build these memories with your colleagues. And I don't think that ends up being something that you dislike anymore.
So the last question we have is, during clinical rotations, what are some common cases that you have witnessed?
As a med student, I'm assuming what that question is. So, correct?
Yes, I believe it's as a med student.
So, in ENT, common cases, tubes, tonsils, lots of thyroids, and lots of laryngology procedures and parotids. Think, and then some sinus surgeries too. But again, keep in mind that, like, it depends on the track that you go, right? So I, as a med student, found my own ENT rotations, and actually that's how I met my mentor. And my mentor was a general ENT, so I worked with him for a couple of months, and those are the things that he did. It's going to be very dependent on who you're doing rotations with. If you're in an American medical school and you're going through a university program, you're going to see flaps for 20 hours. You may have a nice resident like me who will be like, after 2 hours, like, okay, go home. Like, you don't need to stand in the back of the room and not see anything. Like, it doesn't make sense. Go study. So it really just depends on which route that you took and the opportunities that kind of present your way. I mean, you can find, even if you're a Caribbean student, you can go and find a head and neck surgeon who will let you scrub into those flaps with them, if that's something you're interested in. You can find an otologist who will let you be in the OR and let you see under the microscope. And they're not going to let you drill, but like, you'll be able to be exposed to those types of surgeries. So I do think that it's whatever opportunities you kind of create for yourself, you'll have access to it.
Thank you, Dr. Sukaina, for joining us today and teaching us about this field. It was a wonderful presentation. Now, for those watching this, the link to the quiz will be posted on our link tree found in the Instagram bio and has also been posted in the chat box. Our Instagram ID is @we_organization, so please make sure to have a look at that. And within this week, we'll also be emailing your